Carbondale. I'm a physician assistant. Went to the University of Iowa, and then I got my master's from Southern Illinois University in Carbondale. My husband and I lived in St. Louis until 2014 when we moved up here. I did hospitalist and emergency medicine down there. My aunt works at in Vinton, at the nursing home in Vinton, and she's like, hey, Virginia Gay's got a job where you can do both of them. And my parents had moved back here and we were going to start having kids and this and that, so I'm like, great. So I applied. I didn't get the job the first time. They called me back about 6 months later. I think we made the wrong choice. Can you come up? And so I accepted the offer, so we moved up here in 2014, and then I worked at Virginia Gay doing both hospitalist and emergency medicine until 2020. Have 3 kids, couldn't do the 12-hour shift, so now I work at Luke's. I'm in the emergency room there, and then I do this about once a week. So how did I get here? I'm turning 40 Friday, and like last March, a friend of mine was like, well, who do you get your hormones checked from? I'm like, nobody. So I kind of put out a post, and CJ's name came up at least twice, if not 3 times. So she went to see her, I went to see her, because I'm like, well, heck, I might as well get mine. And she's like, well, here's the deal. I'm kind of looking for somebody like you who can prescribe, who can do a little bit more than I can as a chiropractor as far as the functional and integrative medicine side, because she does a great job working things up. But then if people need prescriptions, she can't write prescriptions. So that's kind of where I come in. And she's like, I really just need help with the heart health. Bad lipid panels, but it's kind of morphed into more of like weight loss, HRT, really kind of fine-tuning thyroid, a lot of the hormone stuff, plus weight loss, plus still the cardiovascular stuff, which I really enjoyed, because if I didn't work in emergency medicine, I probably would be in cardiology. So, and I'll just let them kind of, go ahead, you want to just do that? Go ahead.
Sure. Hi, I'm Brittney. I've worked at Back in Line for like 9 years now. I started at just like front desk and then office manager, billing kind of role. I have 3 kiddos, so kind of after I had my oldest, he's almost 6, I started to get a little more interested in like functional medicine type of things, just as like some health things came up, and I was like kind of wanted an alternative route to address what the things that he had going on. So I looked into a functional nutrition course and did that very slowly because I have 3 kids. So it took me a while to complete it, but so I got that done. I started seeing clients earlier this year. Still kind of doing some of the back in line behind the scenes things, but starting to see patients for functional nutrition. So talking about just like nutrition, I can review labs, things like that. Just kind of what Dr. CJ does, but more focused on nutrition and like gut health. I like focusing on kids a lot and like postpartum moms. So in postpartum area, you really can't do a lot, or when you're pregnant, to support your body. So trying to find ways that we can help women through that time when they're not able to. We have some really great supplements that you can't take when you're pregnant or breastfeeding. So like things like that where we can meet them where they are, and with kids as well. So, Missy, you want to go? No, okay.
I'm good.
All right.
Missy's a chiropractor here. She's really good.
This is your guys' show.
My name's Dara. I've known, I think, just the back in line practice since NOM is what I say, but for a long time. CJ's one of my best friends, and I've been utilizing this practice, making my parents come here, blood work, chiropractic care, you name it. And then CJ approached me earlier this year late last year about lifestyle health coaching. I got out of that from a corporate level. I was doing that for about 8 years. Got out of that and then moved into just a functional side of health coaching where I could really kind of elaborate on just more so lifestyle based and how to really make things intriguing for people and desire more out of healthcare and their own personal responsibility too. I was, like I said, a corporate health coach for many years. I worked out in California for a little bit, training women from all over the world, which is very mind-blowing because they were very wealthy women, but they all had the same issues. It was like self-conscious health issues, and they didn't take their health as a priority, but they had all the money in the world. It was just mind-blowing to me that we all still have the same issues, regardless of income or any circumstance. So it's always been part of my life. It's my second hand. I love to talk about this kind of stuff, and I love to be in an office that loves to have these kinds of, not crucial conversations, but good, necessary conversations, and to just allow a little bit different perspective on healthcare too. So,
Okay. So with that, let's get rolling here. All right, so I thought I'd just do a little bit of the evolution of women and heart disease. it hasn't always been women focused. It was really started out as men. As you can see in the 1960s, the American Heart Association actually had a conference entitled, "How Can I Help My Husband Cope with Heart Disease?" which I just was blown away by that. But really, I think the big turning point was the NIH study. Are you guys familiar with the NIH study, the National Institute of Health, Women's Heart Disease? So that is the one in the early 2000s that really blew HRT off the map. Everybody was on, when I say HRT, I'm talking about hormone replacement therapy. Everybody was on hormone replacement therapy. I think it was like 60% of women was on that. Hormone replacement therapy is linked to breast cancer. Boom, everybody stopped it, and that unfortunately is not the case, and it has been revoked several times over now. But really, that study, the women's heart disease study, was really just that. It started as looking at how HRT affects women's heart health, and then it kind of evolved into the focus on breast cancer. So it was kind of unfortunate that that's the evolution that it took, but that's what happened. So that was that time is the early 2000s. So I feel like that's really when the women's heart health kind of came to the forefront. And now that we know that it's the #1 killer in both men and women, but I still think it gets overlooked by breast cancer, by colon cancer, by, you know, the like respiratory pulmonology stuff. But by and large, well, it's known that a combination of cancers, accidental deaths, respiratory problems, and Alzheimer's do not kill as many people as heart disease. So that's why we want to kind of keep that in the forefront. This is there's one death in 80 seconds. I'm not sure if that's women, but that is just the magnitude of heart disease. And heart disease can be so preventable with early knowledge. So that's why we think this is important, and we're happy that you guys are here. So, all right. So how are we different than men? You know, we'll talk about in a little bit that we can actually present a little bit different than men, but really by and large, it has to do with estrogen. Estrogen is cardioprotective, and when we start our periods soon, or when we start them late, and when we go to menopause early, we have a very shorter window of the estrogen influence on the body, and we want estrogen really as long as possible. Also, a lot of pregnancy-related complications are linked to future cardiovascular disease, so that's why we ask that in our intake. Do you have gestational hypertension, preeclampsia, eclampsia, gestational diabetes, preterm deliveries, multiple deliveries, miscarriages? Those are all related to future cardiovascular disease just due to the estrogen and progesterone influence of that. In addition to, you know, with hypertension, it's damaging to your vasculature. When you're pregnant, you have double the blood volume, which is really hard on your heart. So a lot of those things with pregnancy just kind of sets us up at risk for in the future. We talked about menopause and how that's related to estrogen. PCOS, polycystic ovarian syndrome. That is a huge thing, and I don't know what the statistic is, but polycystic ovarian syndrome is insulin resistant until proven otherwise. Insulin resistance promotes the excessive testosterone. Testosterone then is changed to estrogen, and it's non-utilized appropriately. Insulin resistance increases testosterone, so it's all kind of interrelated, and all that stuff really increases your risk for future cardiovascular disease as well. And then the autoimmune diseases, lupus, rheumatoid arthritis, it's all inflammation based. When you have inflammation, you have damage to the blood vessels, and that increases your risk for getting cholesterol where it shouldn't be. So what is cardiovascular disease? Cardiovascular disease is kind of the umbrella, and there's multiple different layers to cardiovascular disease. If you look at the word, it's 2 words, cardio and vasculature. So cardio is your heart, vasculature is in your brain, is in your lungs, is in your legs, and that is all related into the umbrella term of cardiovascular disease. So when we talk about atherosclerosis, that's primarily when we talk about plaques forming in your arteries. Heart attacks is just what it sounds like. Strokes, heart failure. Heart failure is when you have too much blood returning to your heart, and your heart either becomes stiff or becomes like a floppy paper bag, and you can't handle that volume like you used to be able to. So it can end up when you see those, I shouldn't say old people because young people can have it too, but when you have swelling in your legs, that's usually not when you're young, but when you get kind of up there in age, that's a sign of heart failure. When they get short of breath, when they can't lay flat, that's all heart failure until proven otherwise. Arrhythmias is actually under the cardiovascular disease too. So think of the arrhythmias as kind of an electrical problem, whereas atherosclerosis is more the plumbing problem. Working in the emergency room, arrhythmias is a big deal. Atrial fibrillation, ventricular tachycardia, ventricular fibrillation, all that stuff are big deals, but that does fall under cardiovascular disease. And then heart problems, those are usually genetic, you're usually born with those. But as we'll kind of talk about that, there's one particular type of cholesterol that if you have an elevated, it's called an Lp(a), you're at risk for aortic stenosis, so there's some correlation there. So the 3 things, if you don't remember anything of what we told you tonight, I want you to remember the 3 most modifiable risk factors for future cardiovascular disease: smoking, high blood pressure, high lipids. 3 things that you can do to really reduce your risk. So those are the 3 main things. So how we as women, how do we can present a little bit differently? So I work in the emergency room, right? But a lot of different scenarios that I can think of. They present with epigastric pain. Any woman who comes into the emergency room who has epigastric pain is an MI until proven otherwise. Just because sometimes they're like, oh, I have this heaviness, I kind of had this fullness. Men don't do that. But we still get EKGs on men who come in with epigastric pain. And when I say epigastric, this is kind of your area here. But they can have back pain. They can just have this dull fatigue, and we really have to work that up and take it seriously. A little bit of pathophys is why that happens, is because, and I don't know really why this happens, but women can get kind of some blockages at different spots along the same artery, whereas men tend to have one big artery, it clogs it off, and then they have a heart attack. Whereas women kind of have a more insidious, slow onset because they have those multiple small blockages that ultimately decrease the flow of blood in the coronaries. So that might be one of the reasons why we can present differently. So we actually have a different way of collecting plaque. I mean, not all the time, but sometimes. So what is atherosclerosis and how does it form? So it starts with endothelial dysfunction. So when I say the endothelium, this basically look at it as this white line, because you can see that the plaque actually forms underneath this layer. So oftentimes people think that it's a blood clot kind of in the center of this tube. It actually is cholesterol that deposits in the lining of the blood vessels. And that's important to know because you can still have normal imaging and have plaque formation, because the images would just look at this tube, and if you just looked at it from here, it doesn't look that narrowed. But as time goes on, that kind of the 2 walls meet, and that's when you kind of can have cardiovascular disease and plaque formation. So it starts with wall stress, high blood pressure, the constant shearing of high blood pressure in your arteries, inflammation, and I'm sure the girls will talk about that too, but if we have any type of barrier breakdown within the vessels, that allows those vehicle carriers of cholesterol to get in and deposit it where it shouldn't. So the body then, they're like, what is this foreign substance in the walls of my arteries? They actually kind of cause an autoimmune reaction, and they attack this, and then they can form foam, what are called foam cells, and ultimately they can form a clot here. So it's just important to realize that you could still have normal imaging because it's actually in the wall, it doesn't necessarily start in the vessel itself. So that's kind of just the fatty streaks. Your body does a good job trying to stabilize this. They do that by putting calcium into the area that they have found to be inflamed and kind of irritated. That is why, if you guys have ever heard of a calcium CT, those are really good to get. They're $99 at RCI, St. Luke's, or Mercy. So it's a CT scan, doesn't have any contrast, you don't need an IV. It is trying to pick up the calcium deposits in your vessels. And we want calcium to be in those plaques because that makes those plaques more stable. Unstable plaques are the ones that rupture and cause problems. So your body does a good job, and it can pull from bone, it can pull from calcium from what you're eating, but it then deposits that into that kind of wall area to kind of stabilize that clot, which is hopefully what we want it to do. If you have cardiovascular disease, that's what we want it to do. We want it to be stable so it doesn't go anywhere. Okay? All right, so really, what is cholesterol? Cholesterol has been the villain for ever and ever and ever, and it's not. Believe it or not, 80% of the cholesterol that we work with that are in the lining of your vessels that are floating around in your bloodstream is actually what your body has made. 20% of it is what comes from what you eat. So cholesterol is not bad because the body makes it itself, right? So it's important for vitamins, it's important for minerals, cell membranes, hormones, and that's the big thing about the statin argument, and hopefully we won't get into that, but if you guys have questions, we certainly can talk about it. Do you drive your cholesterol too low, then does it affect your hormones? But cholesterol is made for hormones. Cholesterol is needed for hormones. So cholesterol, let's think of cholesterol. Cholesterol is kind of like oil, and blood is like water. So as you guys know from cooking, those guys don't mix. So we are not really concerned particularly about the amount of cholesterol. We're more concerned about this structure here, which is called a lipoprotein. So this is the vehicle that takes cholesterol in the body and deposits it where it's needed. So these structures are what causes the damage, not the cholesterol inside the lipoprotein. Okay, so what else do I want to say about that? We'll talk, and there's different subclasses of this, and we'll talk about that. But cholesterol is carried by the lipoproteins. Think of these as these vehicles, and the vehicles are what causes the problems, not necessarily the cholesterol itself. So, all right. So going back here, I guess. So you can see these kind of little snake-like things. These are kind of these are fictitious, probably, of a picture of a protein. So each lipoprotein has a different protein on the outside, and that protein is what gives its job. Okay. So when we say lipoproteins, we talk about the traditional lipid panel, like your HDL, your LDL. That L at the end of those acronyms there is lipoprotein. High density lipoprotein, low density lipoprotein. There's about 9 or 10 different subclasses of lipoprotein, and each subclass has a different job. So when you go to the doctor and you get your lipid panel done, you probably get triglycerides, you get HDL, LDL, total cholesterol. If you're lucky, you might get like a non-HDL cholesterol, but that doesn't really give us the true story because it's only looking at one type of subclass of the lipoprotein. You're only looking at the HDL. You're only looking at your LDL. We need a marker that gives us a number of the total number of these in all the classes put together. Okay, so so the LDLs is one type. Yes, that is kind of considered more of the bad cholesterol, and think of it as basically it's kind of the bad cholesterol. It kind of gets into places where it shouldn't be. HDL actually is kind of does the reverse. It actually absorbs cholesterol where the cholesterol shouldn't be, and it takes it back to the liver for the liver to metabolize as cholesterol. So you want a higher HDL, you want a lower LDL. The best risk factor, or the best risk marker though, is your ApoB. And I suspect if you've been in traditional medicine, and I am in traditional medicine, I work in the emergency room, but I suspect if you've been in traditional medicine, you probably haven't had an ApoB. I know you have probably. But this is the best risk assessment because not only does each lipoprotein have like an LDL protein, an HDL protein, every lipoprotein has an ApoB. So ApoB gives us a number of every single kind of lipoprotein, not just one. Why conventional medicine? I don't know, but very rarely, unfortunately, is ApoB tested. So there's one other one that I wanted to talk about, which is your Lp(a), and I almost guarantee you probably only a few of you have probably had that as well. So the Lp(a) is the genetic form of cholesterol. You are born with this form of cholesterol. It's kind of up and coming because there are now risk assessments and risk calculators that include this Lp(a) number, but still, I don't know. The American Heart Association recommends you get it at least once a lifetime because it's a genetic thing. Unfortunately, there's no medications. There are some that are coming down the pipe, but currently there are no medications that changes your Lp(a). You're stuck with it. So you basically reduce every other risk factor so this doesn't have anything to cause problems with. We like it as little as possible, less than 10, but when we start, then there's a linear response to the higher it is, the more at risk you are. So above 80 is concerning, and it increases your risk of cardiovascular disease by up to 2 to 6-fold. So it's really important to know. Again, there's nothing to do about it right now except modify and optimize everything else so it doesn't have anything to attach to and cause problems with. And this is also related to aortic stenosis. So Lp(a), for real world example, I have a 45-year-old guy that's a nurse that I work with at Luke's, and he has had a quadruple bypass. I guarantee his is super high, and he doesn't know his because nobody's ever checked it. So I told him to check it, and I told him to check his 10-year-old's. His 10-year-old's cholesterol was 300. So that's genetic. I mean, that is genetic all day long. You need pharmacotherapy your whole life, but you have to know early knowledge is power, and that's what we're here for. So yeah, so those are the two things that I would recommend you kind of look into the best. I don't know if insurance. I think insurance may cover an Lp(a). I don't know if they would cover an ApoB. The closest thing that you could probably get with conventional medicine to an ApoB would be your non-HDL cholesterol, because it would be everything except the HDL. So that's pretty close. Not as good as your ApoB though. Okay. That was a lot of information.
That's me.
That's what I have to say right now.
Whew. All right. I was learning too, so all that stuff scares me a little bit, not gonna lie. My dad had an arrhythmia, and that was a scary situation, so I take interest in it, but I need to do my test,
Yes, you did.
Okay. Okay, so I am here talking more about lifestyle, because that's the kind of coaching I do as well as lifestyle. Sleep. So sleep in the contributing to the cardiovascular disease. So if I could sell anything in the world, it would be sleep. I would not only be the wealthiest, but I would be the friendliest because everyone would love it. Sleep is one of those things. It's like charging your battery. You have to do it all the time, and it rejuvenates everything. So when you sleep, my biggest suggestion is consistency. You guys know at a certain hour of the night, I start declining, and I'm ready because we meet every Wednesday night. And I'm the first one to leave because I am like a 90-year-old, and I probably get to bed at 9:30. So, and it's the same thing on the weekend. So consistency is key. Yes, as a kid, you were like, oh, it's the weekend, let's sleep in. No, do the same thing Sunday through Sunday, same routine, and as consistent as possible. I was just talking to Brittney. I read a book. I didn't read it. I listened to it because it's this big, and that was just too overwhelming for me. So I listened to a book, and it was life-changing. It was Dr. Peter Attia, Outlive, and I'm going to quote him quite a bit here. He talked about sleep and the necessity of what it is. He also suggested things of like, make your room as dark as possible. Dark out shades, no lights, like even the alarm clock, cover it with tape. I have a humidifier in the winter. That thing had like red tape over it. I was a little scared at times because my house was black. If I could paint my walls black, I probably would at this point. My phone is always on airplane mode at night, and I have no lights on in my room. So it's those kinds of things that contribute to getting to sleep and to staying asleep. I know a lot of people have problems staying asleep. Sometimes things as simple as making sure your room temperature is good. There's a thing it's called bed jet. Did CJ tell you about that one too? It's like a $300-400.
No, it's a little more than that.
Okay,
It's
well,
close.
maybe that was
It's close to
before.
Is that the blower then?
Yeah,
I've seen
but
that.
it regulates your temperature, and there's been plenty of studies showing that when you sleep during the night, you have to have a cooler temperature to stay asleep too, because yeah, right. I wish I could get lower, but so consistency with sleep, rejuvenating your hormones, regulating your hormones, that happens at night. There's this powerful hormone. It's called HGH, human growth hormone. It only produces at night, and that is the fountain of youth. It burns body fat, it helps your skin. Again, it's a great thing, but it only produces it at night. So if you're not sleeping, you're not being consistent, that will impact women's hormones. It'll wreak havoc on it, and the fact that you won't get any of the fountain of youth. Like, let's be honest there. Stress. That's the other one. It sounds so simple, like just don't have stress. Right, we all laugh at it because it is. You're gonna have stress regardless of what stage of life you are, from a mother to a parent, or to you're always a parent once you're a mother. I wouldn't know. I just have cats, so. But if you're doing your job, you have big time nurse. You know what I mean? You have stress all the time. So keep that in consideration. But what stress does to a body, we all know it. It's damaging on belief. So stress can show the low energy, lack of focus, headaches. It comes in different forms for everybody. How our body responds to stress impacts differently for everybody. Some people want to hoard out on food. I'm the complete opposite. My appetite goes and I can shrink down when I'm super stressed. I get headaches. My sleep is impacted at that time because you wake up in the middle of the night with your checklist of things to do and what you're missing and stuff of that nature. And if it goes on for a long time, it can impact your hormones big time. It can increase your blood pressure, things of that nature. When I was health coaching, I would always have to check people's blood pressure before our appointment, and you could tell if they're under high stress at a position of work. I coach the police department of all places, and they're going to tell you, oh, I don't have a problem, and their blood pressure's through the roof. So just being cognizant of your blood pressure, checking it on your own, not just in a doctor's office. I always tell people, if you could check it outside of a doctor's office where you don't have that like scapegoat of white coat syndrome, like I'm just in a doctor's office, and really see what your blood pressure is on a consistent basis. Pain, I hold my stress in my shoulders. Everyone impacts it differently. So again, knowing how that can increase your symptoms of inflammation, which is the catapult for all sickness. It's just inflammation. I had some examples here. So they said women with a high stress job have a 40% increased risk of heart disease. With that will always come depression, anxiety, which as women, we, stress over things, the caregiver in us, it's an instinct in us. So we're always worrying about everybody else and instinctively wanting to fix and take care and help everyone else, but kind of neglecting our own selves. So being cognizant, the easiest, learn to say no, don't overload your plate, but making sure you're taking time for you, which is a perfect segue. I think I got this right. The exercise. So this can help with both of the two things above. And I found amazing, 70% of people don't exercise, which was mind-blowing to me. Maybe it's just been so part of my life, it's kind of like brushing my teeth. I realized how important it is to me during COVID when we got kicked out of everything and you had to stay in your home, and how big that was on my mental health. It was unbelievable. You could go walk and all that kind of stuff, but I couldn't do what I really enjoyed to do, and that was just be physically active and lift things and things of that nature. And that was eye-opening to me, a little concerning. So I always say I can't have surgery because I'd probably end up in prison or something by the end of it, because I couldn't imagine not having a release. 77% of our population does not work out, which is crazy. But again, I'm going to plug that Dr. Peter Attia's book. If you can get the audio, it's a long book, but I promise you it'll change your life on how you look at workouts, blood work. Like he talks about all of that, what Jill just talked about, and he talks about working out with a purpose. And I've been working out my whole life, but at the same point I was like, that book changed why I'm working out. Like, why do you work out? And it's for longevity, hence the name. One prime example is he suggests, it sounds so crazy, is working on grip strength. And the reason behind working on grip strength, even women, is at age 60, 70, 80, when you might be living on your own and you can't open a jar, or you can't dial a phone, or you can't carry your groceries. When you start realizing you can't do things, that's when your family's gonna be like, we're gonna check you into a home and you can't live on your own. So it's those scary things that you can't do on your own as you age. But if we have a preventative approach to it, to keep our strength and to keep our bodies doing and being able to be capable at a longer age, that's music to anybody's ears. So listen to this statistic. So, this homework assignment, and you might not all have dumbbells and kettlebells and stuff like that, but you might have access to something that's relatively heavy. And they say for women, for 1 minute, you should be able to carry 75% of your body weight. So, for instance, if someone's 150 pounds and you cut that at 75%, it's 112 pounds. And that divided is 56 pounds in each hand. So it's 56 pounds of a dumbbell, kettlebell, rice bags, whatever you got, and you hold that for a minute. And you're working on your grip, your hands, and your forearms, just to hold that. And that was an ego kill real quick, because I tried to do it for myself, and I couldn't. And it was alarming because I pride myself into working out and being active. But taking the approach of why to work out could really help to motivate you to work out. Because it's not just so I look good in a bikini. Ain't nobody caring at our age, what you looking like in a bikini. We ain't getting in a bikini, nor do we want to get in a bikini. I don't. And it's the longevity and quality of life. Because if you don't, and you have a fall, like your hip, the infamous hip fall, that could be catastrophic at age 50 to 70. At 70, it could be death within 6 months. You have a higher rate of death within 6 months after a fall like that. Some of this stuff can be preventable. So taking the time to have a routine, and people are like, well, was it weight training or is it cardiovascular? And I'm like, yes, yep, both. lift weights faster. I don't know. But if you can start from nothing to something, they said, it was another statistic that blew me away. Going from 0 minutes to roughly 90 minutes per week, which is like 13 minutes a day. That can reduce your risk of dying from all causes by 14%. 14 minutes a day. How much time do we spend on our phones a day? You know, we think about those kinds of things of just allocating your time to what you want to benefit you in the long run. And it's hard to think of things of like you at 75, you at 80 years old. But I want to be that one, you know, like I pride myself in watching the Amish. They're going. They're always on the move. They're always able and an able body. But it's like there's something going right there. So always staying active. I was down, my parents live in Florida, and I was laying out one time and I felt like a bum because this old man, literally he was like 85 or 88, he got into the pool and he was just doing laps. And I'm just laying out and I'm like, oh my gosh, this is embarrassing. And he comes out of the pool and he's like, guess how old I am? Like the worst question to get, right? And I'm like, I don't know, like 70, because you know they're older, but you don't want to, you know, play the idiot. And he told me he was like 87 years old. And he's like, if you don't use it, you'll lose it. And he just walked away. Like, I'm like, was he like talking crap to me? Or like, I was a little taken back, but I'm like, that rang true so well. And he was a doctor too. So if you don't use it, you're going to lose it. So be mindful of that. Be mindful of the activity you do is for the purpose of longevity. And that's the only purpose. So that's what I had on this stuff. And also, let's be honest, exercise can help with sleep, make you really tired. Helps with stress because it's a good stress reliever. If you are lifting weights or just on a long walk, you know, that's a huge stress reliever just to get outside and things of that nature. So definite improvement with cardiovascular risk. Heart training specifically, I tell people, keep in mind interval workouts. So a spinning class is the definition of an interval. Speed up, decline. Speed up, decline. It trains your heart. And like any disclaimer of any health profession to suggest exercise, please check your doctor before you start an exercise program. But yes, I'm a huge component on interval training because you can't do it for long. So if you only have 15 minutes, interval training is perfect. Bring it up, bring it up, bring it up, bring it down. So that's my speech. Brittney, are you up?
I am.
Okay. You want me to press the button?
Sure.
Okay.
Thank you.
You got it.
Okay, I'm going to talk about food and fats and things like that. So when we think about heart health, a lot of times first thing that comes to mind is like Mediterranean diet. So it's one of the it's like the gold standard for heart health, right? So what exactly is that? It's a lot of veggies, fruits, grains, legumes, things like that. Fatty fish. One of the main sources of fat is extra virgin olive oil. We're limiting processed foods, sugar, and we limit red meat. And we'll go into why that is. Another thing that we think about when we think we're talking about fats is like keto diet, right? Like that's kind of been all the rage the last couple of years. So what that puts your body into ketosis, so we're burning fat for energy. So when you're doing a keto diet, you're hitting like 70-75% of your calories from fat. So that can be beneficial to some people and not so beneficial to other people, and it's because all fat is not made the same, right? So like my husband's done keto before, and I'm looking at food and I'm like, that doesn't look like a really great meal. He's like, I'm hitting all my macros. I was like, that's just a ton of cheese. Like this can't be great. It's like, but you know, like when you just do it straight for just your fat percentage, right? We're not looking into what types of fats we're consuming. This is what we get. So that's why when we're looking into these different diets, it really matters the types of foods that we're choosing. So there, like I said, there are some benefits, like helps your insulin levels, HDL, all that stuff. But then you have some individuals who have a problem like absorbing fat, gallbladder issues, or just if you're going to go that route and you want to go it long term, it's a really good idea to do it with a provider and have your labs done throughout to make sure that you're choosing the right fats and that we're not getting things out of range. So focusing on whole foods, not processed ones. So like things like avocados, olives, coconut oil, good fatty fish. The source of your fish is important, so choosing good fish, and limiting all your processed foods. So that's where like all these keto recipes you're sharing with me, it's like bacon and sausage and cheese and like all of these like delicious looking things. I'm like, that can't be great. So that is where like if you Google a lot of keto recipes, you're gonna have to kind of comb through it to be like, okay, which ones of these are gonna actually be beneficial to me. So yeah, heart healthy fats. So things that are helping, they help with hormone production. So those with like adrenal stress and fatigue, we need fats to help our blood sugar stay stable, right? When we eat, we always talk about fat, fiber, protein, things like that. Well, if we don't have enough fat, our blood sugar is going up, down, up, down. That's a lot of stress on your body all the time because your body likes to maintain homeostasis. But if we're up, down, up, down, up, down, that's just a lot of stress on you. So including fats in your diet, which is sometimes I feel like really hard for women because it was like demonized for forever, right? It was like low fat everything. So even like I have a lot of family members that will still go buy like the low fat option because it's so ingrained in them where it's really like we're gonna go like cut out sugar, but we want to add in good fats is what we're gonna focus on. So fat digestion begins in your mouth and your stomach, but most of it actually happens in your small intestine. So they're broken down into fatty acids, and then we use your HDL, LDL, transports them around the blood. Well, you have different lengths of fats. So going here we have short chain, medium chain, long chain. Your short chain and your medium chain are readily absorbed through your small intestine. So they don't need a lot of help getting around your body. It's that long chain. So those are the ones that are found in like your beef, pork, dairy, things like that. They're good for you, for it. They produce energy, help support your hormones, but those are the ones that can get sticky in your blood. So because they're the long chains. That's why in the Mediterranean diet we like to limit the red meat because it's the long chain fatty acid. But going back to the short chain, that's like butter, milk. It's really easy to digest. It helps support your good bacteria in your gut. We always want to keep our good bacteria in our gut happy because that's where most of your immune system is. Your hormones are produced in your gut, your neurotransmitters. It's not sexy, but everything has to do with your gut. So eating these fats, staying full, feeding the gut bacteria is a really great thing. So, it also helps deliver your vitamins and minerals in your body. So you have a lot of vitamins that need like that fat to help carry it around to where it needs to go. Or like if you eat carrots, they say carrots, vitamin A. Well, it's actually beta carotene, and your body has to convert that using fats into vitamin A. So there's a lot of times where you'll eat things, your body has to work to make it the form that your body can use. So fats are really helpful in that. So this is where we're going to get into like different types of fats. I'm not going to get into all the nitty gritty of all of it, but we have different types of monosaturated and polyunsaturated and essential fatty acids. So going over this, there's olive oil, avocado, sesame oils. All these things are monosaturated fats. So they're liquid at room temperature and they become solid. So that gives them flexibility that they can change states, so they're heart protective. They help your skin health. They're a major part of the Mediterranean diet because they're just really beneficial for your heart health. Then we kind of go into olive oil versus canola oil. Olive oil we love. It's antioxidants. It's best used unheated, or if you're going to use heated, we don't want to get this up to high temperatures because it's actually changing the structure of it. So now instead of it being like this guy over there, it's changing the molecular structure. So you're not going to get all the benefits that we want to have in it. And that's the reason we're not recommending canola oil. It's genetically modified, it's highly refined, it's got a higher smoke point, so some people use it because it is a higher smoke point than olive oil, but it's just like it lacks the nutrition that olive oil has. So if you need to cook at a higher smoke point, coconut oil is fantastic. Avocado oil is also really good at a higher smoke point. So not to say you can't use olive oil when you're cooking, but just if you can keep the temperature lower, it's going to maintain the integrity of it, so you're getting the nutrients from it that we want.
Can I ask?
Yeah.
How do you feel about ghee?
Ghee? Yeah, so we use ghee. We like ghee. As long as it's not technically dairy free. So as long as you don't need to be dairy free. Yeah. Do you have you cooked with it very much?
I have.
Yeah. Yeah. I don't have any qualms with ghee. Okay, so then we have our polyunsaturated fats. So these are ones that your body can't make. So you need to get them from either our diet or supplements. We need them for our brain. Our brain's like 60% fat, so we really want to support our brain, support our cognition, our hormones, just cell function. All of that is really beneficial from these polyunsaturated fats. These though are unstable; they easily become rancid, so you want to keep them in the refrigerator. So this is like flax, hemp, chia, pumpkin, walnuts, fatty fishes, things like that. But these are really, really protective for us. So we want the more of these that we consume, because it's kind of all a balance, right? Not all fats are created equal is kind of our vibe here. These fats are really protective. So the more of these that we consume, the more of the not as good, I'm not saying like normal, like fried food type things, but our less beneficial ones we can consume, and it helps us keep in balance there. So omega-6s and omega-3s. So these are also both beneficial, but we are, as the American population, just like in a really bad ratio with these. So if you look like omega-3s, we have flax, hemp, chia, all those things, fatty fish. And omega-6, these are found in, seeds, nuts, those are good, but it's this canola oil. So it's also an omega-6. So when you look at like the American diet, we want to shoot for 1-to-1 ratio or 1 to 2.5 of like a balance of the two, right? The American diet is normally like a 40-to-1. So it's because of this canola oil. People are consuming so many fried foods and things like that, or there's seed oils in our chips and all of our anything processed has got oil in it essentially, right? So our balance is off. So we need to make sure we're consuming a lot more of the omega-3s, which allow us to consume the omega-6s, and it not to be a problem. So why do these fatty acids matter? We need them for our mood, memory, they help our inflammation, hormone function, all of that stuff. So a deficiency of them would lead to fatigue, depression, like skin issues, eczema, things like that, high blood pressure, even infertility. So they reduce inflammation, support healing, they're good for your skin. We really need fats in our diet. So we want to make sure we're adding in fats, good fats, and not keeping them demonized like they have been for so long. So here's some more ways to get omega-3s in your diet. So I know we talked about like red meat being long chain fatty acids, but if you're choosing meat, let's choose good quality meat, organic meat, pasture raised. How your meat is raised will affect the nutrition you're getting from it. So if you're like, no, I can't cut out my red meat, right? You don't have to do that, but just choose a good quality option is kind of what we're recommending here. So always adding in, flax, seeds, you can add those seeds and flax and all that stuff you can add into smoothies super easily. I do it with my kids, they don't even notice because it's really easy to add into an everyday salads and things like that. But I think did you have this part? This is in me.
What's that?
Do you have this slide? This is in me. I think you went over this metabolic health.
Did you put that in?
No.
Surprise!
Surprise!
Extra
Why is it
credit.
here? We don't know where that came from. I can tell you. You want to talk about that?
No.
Okay. I did want to mention though that to bounce off Brittney, you can actually get levels of your fatty acids. Boston Heart has a lab that you can, like I've done it on myself, I've done it on a couple other people, so I know where my balance is at. If I have too many trans fats, if I need more omega-3s, omega-6s, it's not that expensive. It was like $50. So there is ways to test that as well if you're kind of a numbers person like I am. So metabolic health is kind of just your overall well-being. I'm really going off the cuff now. So metabolic health is your heart health. So when we think of your metabolism, it's basically how fast and how easily you use the energy that you ingest. Food equals energy, and then your body uses that food then to do all the normal body processes. But when we have poor metabolic health, we see kind of belly fat, fatigue, cravings or crashes, and then high serum insulin. So these are just some ways to kind of help your metabolic health. I think everything that Dara hit on earlier does this, but in addition, I would say hydration is a huge thing as well. And like we talked about, obviously smoking, that's one of the most preventable risks. So, yeah. Go ahead. Sure. All right, so to kind of end this talk, and then we have some time for questions if anybody has any. I thought we could end it with know your numbers. So these are kind of like, I think there's maybe 5 like objective, I would call them, dare to say vital signs even, that I would think that everybody would want to know. So first one is your blood pressure. This is a little schematic of the best way to take your blood pressure. Like somebody had hit on, I think it was Dara, that, I mean, because people, when they see me in the emergency room, they're in just that, they're in the emergency room, and I don't necessarily feel like their pressures of 160 over 100 are what they're going to be at home. But if they are, that's clearly a problem. So I don't follow people in the emergency room. That's why I work in the emergency room, so I don't have to see them back again. But here, where this is why I'm here, I have a lot of patients that report back to me what their blood pressures are at home. And
Is one more important than the other? The top number versus
systolic versus diastolic, no, they pretty much all play kind of the same. They say when you're younger, the top number is a little bit more important than the bottom number. The bottom number, as you get older, that's a little bit more important. So, So the best way to take your blood pressure is an arm cuff, appropriately sized, not a wrist cuff. That is because as we age, our arteries get stiffer starting in your fingertips, then working up to your heart. So when your arteries are stiffer, if you think about your blood flowing through like a lead pipe versus an accordion, that accordion allows your to kind of expand and contract as needed, and that lowers the pressure inside your arteries, whereas the lead pipe is one speed all the time, and that's when you have high blood pressure. So we would want it on your arm, appropriately sized, feet flat on the floor, back supported, and really they say, I think they recommend you doing it, you're resting for at least 5 minutes, and then I think you do it at least twice. On their website, the American Heart Association, they actually do have a list of approved blood pressure cuffs, because not all blood pressure cuffs are created equal. So it was 120 over 80 to 129 over 89, or 130 over 89 was actually pre-hypertension. Well, that changed, I think, in 2018. So now, technically, a normal blood pressure is under 120 over 80. That 130 over 39, that's kind of when that's actually the stage 1 of hypertension. So we want it less than 120 over 80 on an arm clip. Other numbers that kind of like your vital signs, like we talked about earlier, I hinted at the ApoB and the Lp(a). Those are 2 numbers that everybody should know. ApoB, we like less than 80, but if you have comorbidities, and when I say comorbidities, I'm talking about high blood pressure, diabetes, stroke history, you're a smoker, you have some insulin resistance going on, we would like it actually closer to 60. Your Lp(a) optimal is less than 30, and there is that linear risk of future cardiovascular disease with the higher it is. Probably the highest one I had like 170. I had a guy that had 170.
What's the range then? I thought it was like 0 to 100, but no?
Nope, it's infinite. Like I haven't seen an Lp(a) greater than 250, but I'm on like a forum on Facebook, and there's some guys on there. But you have to be careful. This is a milligrams per deciliter. There is also a nanomoles per liter, I think. So that would be a different number. So by and large, all the labs that we use is the milligrams per deciliter. So if your lab is a nanograms, you got to watch the unit on those. So, and then I think everybody should probably know their visceral fat. And you'll find out yours when you get your in-body. And then bone mineral density, I actually think it does that as well. So, right?
Yes.
Did I make that up?
Yes. No, you're right.
Did I make that up? Okay. All right. So those are good things to worry about too, because just because we're not 65, and that doesn't mean we shouldn't be concerned about our bones, right? Because we want to prevent osteoporosis, because if you already have it, it's kind of too late. And those bisphosphonates that you are put on are really hard on your body. So if we can kind of work to prevent osteoporosis or osteopenia and know it and identify it, knowledge is power, blah, 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 that's probably the best thing for you. And then we kind of hit on earlier the calcium CT. I feel like everybody who's turning 40 should have one. I'm turning 40 on Friday. As I mentioned, in like last month, my husband and I went and got one. So it's a good risk. We use it in risk calculators. If you're kind of, you come and see me, I put all your information in a cardiovascular risk score. You're in that intermediate risk, which is like 8 to 15%, which would be your 10-year risk score. That's that intermediate. And if you have a calcium CT of 0, then that might bring you back down to that low risk, and we can kind of buy some time and we can work on lifestyle. But if you're in that intermediate risk and your calcium CT is 250, we need to do something about it yesterday. So that's kind of where we can use, and it's just a good baseline to have. I don't necessarily think you have to repeat these often. Actually, they say you don't really even need one, but I probably would repeat it maybe every 10 years or so, just to make sure you're still at 0 or you're still at whatever. Now, there are some pharmacotherapies that you could potentially be put on that might raise your calcium CT. That's a potential myth of what you've heard for statins. Yes, statins raise your calcium score because it causes your body to put calcium in the plaques, which is what we want. So your score is going to go higher. It's those plaques that do not have a bunch of calcium, that are that volatile plaques. Those are what's going to get you in trouble. And the statins actually put calcium into it. So that is why your calcium CT may go up if you're on a statin. That's another little myth that I hear. So that score about greater than 100 is kind of when we're like, and that's the number that they use on their risk calculators too, is 100. So like just for instance, my mom had one and hers was 0, and my dad's was like 35. So both pretty good. Don't forget your in-body. Okay, So is there any questions that any burning questions that anybody has?